Good morning, everyone. All my friends over there in US as well as those who are here in India. And I'm very glad to invite you all for this very important and CME of being conducted by Andhra Medical College on COVID-19. This is a very important milestone. That is the 75th episode of this particular program. So I thought it is very appropriate to have the opening remarks from one of the very key persons in the AP healthcare system. So similarly, we have been conducting this for the last 75, not exactly weeks. In between, we had many together, but almost a year. And we are very glad that many people got benefited by these webinars. And I'm very glad that many of our friends, both from India and abroad, have participated in this, contributed their knowledge for the benefit of everybody. To name a few, Dr. Sridhar Chilamuri, the chairman, Bronx, Lebanon, Bronx Care Hospital, New York, Dr. Kairam Ramohan are the pillars who have taken this forward when we were in the deep trouble during the second wave. And similarly, the many illustrious personalities who have contributed their knowledge. And for the 50th episode that we had, which was another milestone, our district collector, Vinay Chand, has given us the very encouraging words. And so I thought it's very appropriate to invite somebody who is very inspiring to all of us. And the scheme of the program would be, I'll be introducing Dr. Vinod Kumar and then later inviting him to deliver the opening remarks. And after that, I'll be introducing Professor V. Rajshekhar and Dr. Professor Rupa Vedantam also together. And later, I'll be handing over to Dr. Rajshekhar. And after both of them make their presentations, we'll have the discussion. So as you are all aware, Dr. V. Vinod Kumar, IAS, belongs to 2015 batch of IAS, a medical doctor, graduated from the Bangalore Medical Colleges, is playing a very key role in the AP health system management system, because he is the project director of AP Health System Strengthening Project, which is a very, very important. And he is the one who is conducting various webinars to empower all the doctors at all levels throughout the state by conducting the AP webinars on one hand. On the other hand, he is looking after the requirements of the infrastructure at the various places, starting from the primary level to the tertiary levels. And simultaneously, he is heading the team, which is actually making decisions and making protocols to be followed by all the doctors and the staff throughout the state. So he's making this is very, very vital at the present scenario, and he has contributed significantly for the effective management of COVID in the state of Andhra Pradesh. And I'm very glad to introduce him to all of you to make his opening remarks, after which I'm going to introduce Professor Rajshekhar and Professor Rupa. So over to you, sir, Dr. Vinod Kumar.
Thank you, Dr. Sudhakar. Am I audible?
Yes, sir, absolutely.
Thank you. Thank you, everyone. Good morning, ladies and gentlemen. I'm glad to be associated with Andhra Medical College, and I thank you for making me part of the daily CME, which has now seen the light of 75th episode. I congratulate the whole of Andhra Medical College led by Dr. Sudhakar. First of all, 6:30 a.m. early morning club. I'm reminded of my postings in BMC group of hospitals, especially the NIMHANS, wherein the director would always say that the top leadership should be first up, and he would be in his chambers, and followed by him would be the head of the departments, professors, and students. And my trust with the Andhra Medical College was when my IAS colleague in my batch was a graduate from Andhra Medical College, and now he's working in West Bengal. I was very much impressed by his knowledge, because in IAS we would see somebody who would not be so passionately a medico, but would be passionately an administrator. So having seen him and having closely associated with him, I got a feeling that probably the Andhra Medical College would be one of the best medical colleges. My second tryst with the Andhra Medical College was with the King George Hospital, when I was POITDA Parvatipuram, and we had a small cell just outside the entrance of King George Hospital, which I would fund it. And I had also appointed few of them to take care of, especially the ladies who would be referred to KGH for various delivery, obstetric, anemia related issues. And I had inspected KGH once to see how our patients were doing. Later, my association with Andhra Medical College is now itself when I'm in health department. And I could see a lot of similarities with Andhra Medical College and Bangalore Medical College in the way they deliver the quality and the passion we all have for medical science. Pedagogy is an important part of medical education. An interest to know first and then to do should be the norm for anything, and medical science actually leads that. What Abraham Lincoln said, that if you give me 12 hours to cut down a forest, I would spend 10 hours sharpening my weapon and only 2 hours to chop it off. Thank you for being part of the AP Kavanaugh as well. There were a lot of luminaries, including Dr. Sudhakar himself. Dr. Sudhakar led the Mucomycosis series, and he also brought in a lot of his faculty to train all the medical professionals of Andhra Pradesh. A special contribution was made during oxygen shortages, wherein Andhra Medical College hosted a series of oxygen therapy, including how to use specific equipment, and there were various demos were also given. Honorable CM of Andhra Pradesh is very passionate about health, and health is his priority. Consequent to that, he has started 16 new medical colleges, and I'm sure Andhra Medical College would be leading and would stand as a benchmark to which all the medical colleges would be following and reaching out to. Any community in the world will become influential, important, if it is not existing individually, but if it is existing as a syncytium, which is now at display. I can see Andhra Medical College doctors attending the seminar, also very concerned and passionate doctors across the globe reaching out to Andhra Medical College, not only AMC, but to Government of Andhra Pradesh as well. We have few experts who are alumni of Andhra Medical College on board of the AP Clinical Expert Committee for the Management of COVID, AP COVID response. I would like to conclude my opening remarks to invite all of you to think on one lines. Doctors are very good individually. They deliver, they are the best, and usually doctors are known by their individual name. There are very few scenarios where doctors are known as a team. Doctors, we should know to be team leaders, to be able to work in teams. I would like to quote the example of Vikram Sarabhai, where he was a very passionate scientist to start with. Later on, he goes on to say that scientific community needs leaders, and that's how the whole space scenario of India was built from scratches. It is high time that doctors also become leaders, doctors become administrators, because the COVID scenario showed us all that knowing only medical science would not help, but we would have to build health systems and put in a system where the medical science, treatment to the people, saving lives becomes a routine inside of that system. Thank you, Dr. Sudhakar, for giving me this opportunity. All the best to all the people participating in this webinar, and my best wishes to the college. Thank you, everyone.
Thank you very much, sir, for your encouraging words as well as your directions. And this being the 75th webinar that we are having, I thought that we should have very illustrious speakers for this particular program. And hence I invited Professor V. Rajshekhar and Professor Rupa Vedantam to deliver, who are considered as one of the topmost clinicians in the country. And now it's my pleasure to introduce Professor V. Rajshekhar, the Professor of Neurosurgery at Christian Medical College, Vellore, for the past 25 years. And he was the past president of the Neurological Society of India, the Indian Society of Stereotactic and the Functional Neurosurgery, the Indian Society of Neuro-Oncology. He has more than 320 papers in the peer-reviewed journals. He has more than 9,900 citations with an H-index of 50. He has delivered 17 orations, including the inaugural Suraya Khanum oration of the University of Cape Town, South Africa. He was the recipient of Basanti Devi Amit Chand Award for the year 2007, which is conferred by the Indian Council of Medical Research, which is the second highest honor of the ICMR. And it is looking at the biodata, we can understand the stature of the individual. And next it is Professor Rupa Vedantam, the professor of ENT from Christian Medical College, Vellore, since 1997. She was the former head of the department of the ENT and the best outgoing student of MS ENT of the Madras University. And she's the adjunct professor, Flinders University, Australia, from 2003 to 2005. She had her undergraduate and the postgraduate teacher. She has been the UG and PG teacher of CMC for over 30 years. She has 90 publications in peer-reviewed journals, and she authored a book on emergencies in ENT. She has a special interest in fungal sinusitis, CSF rhinorrhea, juvenile nasopharyngeal angiofibroma, and epidemiology of the otitis media. And with this background, we thought that to talk about the mucormycosis from those people who have the first-hand knowledge of this particular disease in the present scenario where we are dealing with hundreds of these cases, I thought that it would be appropriate to have this particular topic for discussion. First, I would request Dr. Rupa Vedantam to speak of the ENT aspects of mucormycosis. Later, the neurosurgical intervention will be talked about by Dr. Rajshekhar Vedantam. Over to you, Madam, Dr. Rupa Vedantam. You can share your screen.
Yes, thank you, Dr. Sudhakar, for that nice introduction. And I'd also like to thank the members of the Andhra Medical College Alumni Association for inviting me to make this presentation. Now, I have spoken about fungal sinusitis to many audiences, and most of them were ENT surgeons who were very familiar with the disease. But today is unique because I am going to speak to a mixed audience, and so I will be aware of this and cover quite a few of the basics. Now, many of you would have seen headlines in newspapers and in the media. Okay, is it? Excuse me, I'm going to stop here. Is my screen being shared? Is my screen being shared?
No, not yet, madam. You please share the screen.
Sorry, I will just go back to my first slide. No, I'm doing it. Is that okay?
Yeah, it's fine, madam. You can put it in.
Is that right?
Yeah, absolutely. Okay. Perfect, madam.
Fine. So 2 years back, 3 years back, we had our centenary celebrations. This is a facade of our institution, the Christian Medical College, Vellore. So as I was saying, the public interest in mucormycosis was sort of stimulated by headlines like this at the BBC, talking about the black fungus among patients, COVID patients in India, and the Times of India about COVID patients losing jaws to mucormycosis. So the lay public became aware of black fungus. And for us, calling this black fungus, as you'll see in my talk, it is something quite different. We really don't refer to mucormycosis as black fungus, and we really are quite puzzled why this is called black fungus. But what is black fungus? And to sort of understand this, I will share with you the classification of fungal rhinosinusitis. This is a problem that we've been dealing with for years. But it's really important to understand the classification and to know that broadly fungal sinusitis is divided into non-invasive and invasive categories. And mucomycosis comes under the invasive category, in fact, the acute invasive category. Invasive, you can see here, is divided into acute and chronic invasive. Mucomycosis is an acute, rapidly progressing, often fatal, uncommon it says, but actually quite common nowadays. And it's an opportunistic infection of the paranasal sinuses, which then spreads to the orbit, to the palate and alveolus, and then even sometimes intracranially. One study from India estimated that the prevalence is around 140 cases per million. But in this present epidemic, mucomycosis epidemic during this pandemic, the number has really shot up. Now, one time we actually analyzed all our cases of fungal sinusitis, numbering 266. And as you can see, the red and the blue segments of this circle are the cases of non-invasive fungal sinusitis, that is AFRS and fungus ball. Now, these constitute the majority of cases of fungal sinusitis that we see. The invasive categories are much less, but of the invasive categories, this green category, that is acute invasive fungal sinusitis, is the most common. Acute invasive fungal sinusitis, I told you about its characteristics earlier, that it's acute, short duration, less than 4 weeks. It is divided into two main subcategories, mucomycosis being the main one, and it's the two main organisms that are involved in the causation of mucomycosis are the Mucor and Rhizopus species. There are other species too, but these are the two most important. Of these, Rhizopus is far more commonly seen. The second category is acute invasive Aspergillus. Now, that hasn't received as much attention simply because it is not as common during this epidemic, and it is in general much less common than mucomycosis. Now, what about the characteristics of these fungi? These are filamentous fungi or hyaline molds. They're actually colorless. So I'm not quite clear why they are called black fungus. The Mucor and Rhizopus species belong to the class Zygomycetes. As you can see here, they form broad aseptate hyphae. And these hyphae are obtuse and they do not have septae. The organ of reproduction, which is the sporangiophore, contains its globose in shape and contains numerous spores. In contrast, you have Aspergillus species. These have actually very narrow, slender hyphae, which are septate, and they have acute angle branching. And their organ of reproduction, the sporangiophore, is more radiate in nature and almost medusa-like. Now, histologically, what do we see in mucomycosis? Well, the organism tends to invade mucosa, submucosa, blood vessels, and bone. And you can see an acute infiltrate characterized largely by neutrophils, these hypersegmented cells, nuclei that you see in cells. These are neutrophils. And this is the typical picture. Angioinvasion is a very common finding, and you can see here how the fungi have actually invaded a thick wall blood vessel full of clot. And if you were to see these fungi more clearly, you would need to stain these fungi with fungal stain. And here you have the GMS stain, Gomori methenamine silver stain, which helps to highlight the fungi. Now, there have been differences that we have seen in the pre-COVID and COVID period in terms of the predisposing factors. Now, in the pre-COVID period, we largely saw patients with poorly controlled diabetes, patients who were immunosuppressed, for instance, if they had a renal transplant or liver transplant and were on immunosuppressants, patients with hematological disorders like leukemia. These were the kinds of patients that tended to present to us with mucormycosis. But in the COVID period, what we're seeing is a large number of fairly normal patients who were given steroid therapy, and then some of them turned diabetic and, were not aware of it. Patients who were diabetic but whose sugars were not monitored, and then they developed uncontrolled diabetes. We know from studies done quite some time back in the time of the SARS epidemic that the SARS-CoV-2 virus, which is just a cousin of the COVID-19 virus, damages the islet cells of pancreas and can cause acute diabetes. Now, that really is one of the chief causes for relatively normal patients developing diabetes all of a sudden and then going on to developing mucormycosis. And then a large number of patients with COVID develop pneumonia, and they are given, unfortunately, potent antibiotics, which again predisposes to mucormycosis. So let's look at the pathogenesis. Now, I'll just briefly run through it. Basically, what we need to understand is that there is innate immunity at play when the spores invade the mucosa, respiratory mucosa. Once they penetrate the mucosa, they germinate and form hyphae. That is when these three categories of cells, the macrophages, neutrophils, and dendritic cells, are involved in phagocytosis. Now, these dendritic cells, when they phagocytize the hyphae, they then proceed to the lymph nodes and cause differentiation of the naive CD4 and CD8 cells into Th17 and Th1 cells. And this then leads to the release of a number of cytokines and chemokines, which further increase the destruction of these hyphae. The hyphae of Rhizopus and mucor has a predilection for blood vessels. I told you about angio invasion earlier. They have a great affinity for the endothelium of blood vessels, which they tend to penetrate, cause platelet aggregation, and this then causes thrombosis with resultant infarction. Now, in the presence of hyperglycemia, as also in the presence of acidosis, as you get in diabetic ketoacidosis, as well as when serum iron levels are raised, you find that these fungal hyphae proliferate. So when a person receives steroid, you can well imagine that there is hyperglycemia, and this leads to increased amount of invasive fungal sinusitis. So that being the pathogenesis, we can see from these scans how mucor proceeds. So you have initially sinonasal disease, which then through an intact bone can spread to the orbit and through vascular and neural channels, and then either directly or via the orbit to the intracranial compartment. This is the way mucor spreads, and it is not really through the production of huge mass lesions and bone erosion. Now let's look at the demography in the pre-COVID and COVID era. I've just taken 90 of our most recent patients that we have seen as a comparison. We have seen a lot more patients since then. Now, the sex distribution has been, the pre-COVID and COVID periods are roughly the same, and so also the age distribution. But as you can see here in the COVID period, there are a lot more diabetics that we are seeing, an upsurge both in diabetes as well as mucormycosis. The clinical features are very typical, and one wonders why it is that people are not familiar with this. This is something that we have published a few years back from a series, and it hasn't changed very much even in the COVID period. The chief symptoms are headache, facial pain, ocular symptoms like proptosis, ptosis, periorbital swelling, some degree of facial swelling, then oral dental symptoms like loosening of teeth, swelling around the tooth, oroantral fistula, and nasal symptoms are not so common, but some of them will have nasal congestion and rarely epistaxis. When the disease progresses, you will have patients who come to you with altered sensorium and focal neurological deficit or seizures. Now, here are some very typical clinical pictures. This gentleman here has facial swelling, periorbital swelling, and swelling in the region of temple, which indicates that there is invasion of the infratemporal fossa. This gentleman here has periorbital and facial swelling, as also ptosis, and he probably has a frozen eye, which is what happens when the eye has been invaded. Now, this lady here has discoloration of the skin, black discoloration, and this may well be the reason why this is called black fungus. There is ulceration. These cases are caused by ischemic necrosis and gangrene of the tissue, his skin tissue, and will involve a lot of resection and reconstruction at a later date. The next step after a clinical examination, an overall clinical examination, would be to do a rigid nasal endoscopy. And in the vast majority, what one will see is there is pale or discolored or very unhealthy looking nasal mucosa, as seen in the first picture, and there will be purulent discharge. In about 10% of patients, you will see a black necrotic turbinate. Maybe this is why it's called black fungus. There may be erosion or total absence of the turbinates or a big septal perforation. And in about 10% of patients, we see an absolutely normal nasal mucosa. Now, these are the cases where it's important to have a high index of suspicion and proceed with the investigations, which I will now talk to you about. Now, after examining the nasal cavity, one should remember to look at the oral cavity. One should not omit this very, very important step, because you may miss out on very important findings by which you will be guided towards planning your surgical plan. So a palatal ulcer with exposed necrotic bone is something one can see. And this is one should carefully look for in the region of the hard palate. You may see discoloration of the palatal mucosa or sometimes a palatal bulge and a lot of necrotic teeth on that side. You may see an oroantral fistula. So a dental evaluation is essential to see which are the affected teeth. And just sometimes you may actually see this black eschar, and maybe this is why it's called black fungus. That is something that should alert you that you are dealing with mucomycosis. Now, this very patient may have an absolutely normal nasal mucosa. What are the investigations that we do at that point? We've made a clinical presumptive diagnosis. The first step is to send an urgent KOH smear, potassium hydroxide smear. And the tissue that is taken, it's better to avoid taking pus because it may not yield much of the fungal hyphae. Send small amounts of the affected tissue. The site of biopsy should be the most affected site. But if it looks fairly normal, the middle turbinate is really the site from which one should take a biopsy. At the same time as sending specimen for KOH smear, you send a biopsy and frozen section if possible, if you have the facilities, because you want an early diagnosis to institute treatment early. Then, of course, one should do blood tests to assess the patient's diabetes, check if there is renal involvement, check the electrolytes, see if there is evidence of immunosuppression or any other cause for predisposition to mucomycosis. Next step would be to do radiology, of which a contrast-enhanced CT scan of the paranasal sinuses is essential. And when you suspect orbital or retromaxillary or intracranial involvement, it is important to do a GADO-enhanced MRI scan. What are the findings on CT scanning? And this is something one should be aware of. One important dictum that one should remember is that the involvement of paranasal sinuses is not very evident when you look at a plain CT, at a contrast-enhanced CT scan. As you can see here, there is minimal involvement, mucosal thickening in the left maxillary sinus and a little bit involving the left middle turbinate, and the adjacent nasal mucosa. The rest of the paranasal sinuses look apparently clear. Now, this can be misleading. The mucosal thickening may be enhancing in some patients, but if it is enhancing, it's very mildly enhancing in most patients. Bone erosion is not common. Now look at this next axial cut, a contrast enhanced scan. You can see that there's very minimal ethmoidal sinus, right ethmoid sinus in mucosal thickening, but this patient actually has orbital apex involvement. So even though the sinus involvement is minimal, you have this patient coming to you with proptosis and evidence of orbital apex involvement. So that is important to recognize. Now let's go in a clockwise direction below. And here you can see that this patient has got premaxillary involvement. The soft tissues of the premaxillary area show fat stranding. You also see involvement of the maxillary sinus. And even the retromaxillary area, you can see a nice hypodense area representing the retromaxillary fat on the uninvolved left side. On the right side, you can actually see that there is a lot of fat stranding due to involvement of the right pterygopalatine fossa and infratemporal fossa. Now looking at the next slide, the next picture, this is an axial cut. And here one sees that there is mucosal thickening in the right ethmoid sinus. There's also quite a bit of fat stranding in the right orbit. You see involvement of the right superior orbital fissure, as well as absence of enhancement of either the Kavanaugh sinus or the right internal carotid artery. You have the left side here to compare, and where you can see that there has been uptake of contrast. So these are common radiological pictures in patients with acute invasive fungal sinusitis, typically in mucomycosis. Now, these are GADO-enhanced MRI pictures, and you can see here that in a patient with orbital apex involvement, there is enhancement of the apex, and there is also enhancement of the cavernous sinus on the same side. In this particular picture, the next one on the right, it's a coronal view of a contrast-enhanced MRI scan of the sinuses, and you can see enhancement in the left middle turbinate, nasal mucosa, and the opposite side turbinates. And interestingly, in the left maxillary sinus, you can see an area that, along with the inferior turbinate, is not enhancing. This is sometimes called the black turbinate sign. It's not often seen. And this is simply because of not the lack of enhancement, because it is infarcted actually because of thrombosis due to mucomycosis. Not commonly seen, but this may be one reason why this is called black fungus, because it does sometimes produce the black turbinate sign. Now, this last picture here that you can see, and you'll hear more about this from Dr. Rajshekar, but here you can see a patient who's got a right temporal lobe abscess, as also another abscess in the right infratemporal fossa. The same patient has got involvement of the right ethmoidal sinus, and interestingly has had an orbital exentration, probably done outside, and then referred to us for the intracranial complication. Now, we did actually study these various imaging features and had a publication on this some years back. The chief guest for this meeting talked about doctors working as a team, and this is no better illustrated than with the management of mucomycosis. As you can see here, we have need a multidisciplinary approach in the management of these patients. The prime movers, I feel, should be the otolaryngologist. You have the endocrinologist or the hematologist to deal with the diabetes and any other hematological cause. The anesthetist, because these patients are often very sick and high risk for anesthesia. The pathologists and microbiologists. Pathologists sometimes, unless you sort of take them into confidence and stimulate their interest in mucomycosis, you will not find that they are finding muca in many of the specimens, and it is important for them to look at a lot of these specimens. The radiologists to interpret the scans, ophthalmologists because their intervention is sometimes required, and for the assessment, neurosurgeon, of course, when there is intracranial complications, The nephrologists, many of them have diabetic nephropathy, or the treatment for it causes renal damage. You need a nephrologist. The oromaxillofacial surgeon, sometimes prosthodontist, and the internal infectious disease specialist or internal medicine specialist. All of them are very, very crucial to the management of these patients. So let's just run through our protocol for the management of these patients. We start with a clinical workup, do the bloods, and then, of course, in this COVID period, do a COVID test. We do a rigid nasal endoscopy, complete clinical examination, send the specimen for fungal culture and a frozen section 2, which is avoided during the COVID period. CT scan of the paranasal sinuses, and if the orbit or brain is suspected to be involved, yes, we would need to do a GADO-enhanced MRI of the paranasal sinuses, orbit and brain. You send the consultations to ophthalmology, neurosurgery, control the sugars. They may have diabetic ketoacidosis, electrolyte imbalance, all of that should be addressed. Once you know the COVID status, obviously, these patients need segregation. If you do get a positive smear, you can start antifungals because these are very sick patients and need treatment. In the pre-COVID era, we would wait for the biopsy, the frozen results to start antifungals, but now we do not hesitate to start antifungals and then proceed with urgent debridement. The approaches we use largely depend on the extent. The endoscopic approach, maxillectomy, and orbital exentration are some of the approaches. I'll talk more about it later. Even if you get a negative smear report, it's important to go ahead with urgent debridement because sometimes it is the volume of tissue that will give you a positive result. Now, during the COVID period, there are some important precautions that we need to observe because we know that the highest viral load is in the nose and paranasal sinuses. Use of complete PPE is essential because these are aerosol generating procedures. Some surgeons, they're not at our institution, but I have seen private practitioners have these powered air purifying respirators. They're good. Individual surgeons can use them and allows you to do fairly long periods of surgery. This is a little uncomfortable, but sometimes we just have to sweat it out. One does a betadine wash of the nasal and oral cavity first, and then, of course, have a separate OR for COVID patients, and there should be as minimal personnel as possible when you have a COVID patient being operated. The surgical protocol that has been described in the literature, and here I have 3 studies taken from the West. And you can see that the number of surgeries, 2 to 6, and even up to 8 surgeries in one series. Now, we were also doing multiple surgeries at one time, and we found it quite difficult actually when our patients, these are very sick patients and high risk for anesthesia and need ICU care. They are usually quite strapped for money, and these are expensive procedures. So we then tried to look at sometime in 2017 to see whether we could combine, make it all into a single procedure after complete evaluation. And so with the single procedure from 2017 to 19, we operated on patients after evaluation, and combining that, the bilateral endoscopic sinonasal debridement with the maxillectomy, with or without orbital debridement or exentration as indicated. And with this protocol, we interestingly found that the revision surgery rate reduced from 28.1% to 3.9%. We published our results recently. Our outcomes also weren't very different, 63.6% in the earlier era and 68.2% when we adopted this single procedure protocol. And it was a little higher, 73.5% among diabetics. So we continue to follow this procedure to the extent possible. The other interesting finding we found in this study, that as we examine the histological findings, as if you remember, I said that we operate bilaterally, and each of the sinuses is separately, the tissues from each sinus are separately labeled and sent for histology. So we found that in, say, a case like this, sampling of the right maxillary and ethmoidal sinuses Although they clinically and radiologically appear negative, we found that they were histologically positive. This was something that we found in 6 patients, and so it emphasized the need to explore both sides in all patients, and doing a single procedure completely is really what we find helps the problem and reduces the numbers of repeated surgery. Now, what are the findings interoperatively in these patients? In most patients, you will see something that looks like this. This is the left ethmoid sinus. This is the lamina papyracea, which separates the left ethmoid sinus from the orbit, which is medially. Now, laterally. This ethmoid sinus has some thickened mucosa lying against the middle turbinate. This is the most classical picture. Sometimes it looks very unhealthy and necrotic. In yet other patients, you might find fungal debris. This is a classical peanut butter-like material, black, decaying material that you might see, and interspersed with the edematous or unhealthy mucosa. And then yet other patients, especially those who have bone involvement, where there is bone erosion and necrosis. This here is the sphenoid sinus. This is the root of pterygoid. The root of pterygoid was necrotic in this patient, and this was something that we had to debride. So you can see any of these 3 pictures in these patients. With respect to the palate, you often see a necrotic ulcer with sometimes this black eschar, again black fungus. And it's important to do a wide debridement. Of late, we have been trying to preserve as much palatal mucosa as possible. So we tend to go subjacent to the mucosa and remove all necrotic bone, and if possible, suture the remnant of palatal mucosa to the buccal mucosa. And this sometimes helps patients because they can avoid using a palatal prosthesis. Now, as far as the sinuses go, it's important to completely debride this area, remove all the unhealthy mucosa, and if required, even resect the middle turbinate. In this particular patient, we have cleared the sinus, but because the middle turbinate looked fairly healthy, we had preserved it. But one can, in any suspicion of involvement, resect it. What about orbital exentration? Now, this is a very controversial topic, and I just brought it into this presentation because a lot of people are curious about this. So I looked at one meta-analysis, which is very large, by Hargrove and co-authors, 113 articles over a long period. And they unfortunately or fortunately have shown that there are conflicting results, and they concluded that there was no standard of care exists to guide physicians regarding the need for orbital exentration in mucormycosis. Another study from India showed that orbital exentration is not required in the majority, and debridement of periorbital tissues is sufficient. And really, this is what we tend to practice at our hospital. In most cases, just a periorbital debridement is sufficient. Our ophthalmologists make this decision, and sometimes they themselves are not quite sure whether they are on the right track as yet. Most often we excise we debride the orbit and have a very high threshold for removing the orbit. And many patients are also quite unwilling to have their eyeball removed. Now, in terms of antifungal therapy, that is what is the next step. Once you finish the surgical exploration, either before or soon after, one commences antifungal treatment. And when you start talking about antifungal therapy, the first name that comes to mind is Amphotericin B. This is literally the workhorse for invasive fungal infections worldwide. Amphotericin B comes in 3 main avatars. You have the plain amphotericin B or deoxycholate or conventional amphotericin B given at a dose of 1 milligram per kilogram body weight. Then you have the liposomal amphotericin B given at a dose of 5 to 10 milligram per kilogram body weight. And this is really the drug of choice as per the most guidelines, the American as well as the European guidelines. Finally, you have the lipid soluble amphotericin B. This has fewer of the side effects of the plain or conventional amphotericin B, but is certainly not as effective as the liposomal amphotericin B. If you look at the cost, I've put it in dollars because, sometimes it's interesting to know what it is in dollars. And you can see, obviously, the cheapest is the conventional amphotericin B. And it is indicated in all patients with rhizopus or mucor infections. With Aspergillus, the drug is different. So in terms of toxicity, and this is one of the main problems with amphotericin B, it is both expensive and toxic. So one wonders why one should choose this drug, but really we have very little choice. What are the toxicities? Renal toxicity is what is described most often, and you can see this is much, much more for conventional amphotericin B, 86% versus 1.4% for liposomal. Central and peripheral line thrombosis is something that we see once in a while, 15% of patients. Hypokalemia, hypomagnesemia, fever and chills are also something that the patients can get. And sometimes some of these complications lead to discontinuation of the drug, and that really affects the patient's prognosis. The next group of drugs are the azoles. And of this, what you hear a lot about nowadays is posaconazole. Posaconazole used to be available in India chiefly in the syrup formulation, and it was given at a dose, loading dose first at 200 milligram per 5 ml is what it was available in, and very expensive. The tablet was available, interestingly, started just before the first wave of COVID. And just before 2019 end, it became available in India, and it is something of a godsend. It was almost as if it was sort of planned for the COVID period, and now we find that is literally freely available. I forgot to mention that the antifungals amphotericin B is currently very, very scarce in India, and many cities report that not even one hospital has got amphotericin B for their patients. So we get a lot of referrals like that, but it's not to say that we have a lot of amphotericin B. We also are constrained to treat patients with full doses because of lack of the drug. Posaconazole being available orally is a drug that a patient can be discharged with. And this is really the main advantage because it is not a first-line drug. I think there are just 1 or 2 studies in the West that have looked at posaconazole, small studies with 3 or 4 patients, and is just by and large not recommended as a first-line therapy. It has been given for step-down or salvage therapy. Isavuconazole is also effective, but it is expensive and not freely available. Both of these drugs do not cross the blood-brain barrier to a great extent, and so are not preferred to amphotericin B unless you obviously absolutely require them. Voriconazole is the drug of choice for Aspergillus infection. Unlike amphotericin B, there are good, robust randomized controlled trials which have shown that it is the drug of choice for aspergillosis. Now, we actually had a study. There have been some studies in the West with small series, and we also a few years back published this. We had 12 patients with stage 3 disease. That is, they had intracranial or deep skull base involvement. This was posaconazole given as salvage therapy, and 67% showed complete resolution of disease. And so this was very encouraging. These patients all received syrup posaconazole as the tablet form was not available at that time. What about antifungal susceptibility testing? Now, as far as antibiotics go, we know that we do that once in a while when we find that patients do not respond to a particular antibiotic. But antifungal susceptibility testing has not received much popularity across the world. Now, why is that so? While you can find low MICs, that is minimal inhibitory concentrations for for amphotericin B and the like, you may find that there is no significant association between AFST and the in vivo response. And this is largely because the breakpoints for AFST are not well established. One study that we did recently actually showed low GM-MICs for amphotericin B for rhizopus infections. However, there was no association between AFST and the in vivo response. And this is, of course, though, largely because of therapeutic complications from conventional Amphotericin B therapy. So still the jury is out on this. I think more studies need to be done on this. Now, once the patient has been treated, the involvement with the patient is incomplete. Rehabilitation is also important, and this again is a multidisciplinary approach, and we have to follow up on this with our patients. Rehabilitation of the eye, one can replace with the eyeball, and for the teeth, first a temporary prosthesis so that to allow swallowing and speech, and then of course a permanent prosthesis with teeth. Now let's look at some of the figures that we have here for the numbers of patients that we have seen in CMC. Actually, ours, when we looked at the data, and this was from an association with PGI Chandigarh, which also sees a lot, we found that our hospital actually contributed the largest number of patients with mucomycosis to a series that was done from India a few years back. So we can see that there's an increasing trend through the years, and this sharp upsurge is what we see during the COVID pandemic. And here we have data from January to December for 2020 and 2021. In 2020, when January to about June, we had our usual numbers of patients, but by the time it became July and slowly, progressively to the peak of the first pandemic in September, we found a sharp increase in number of patients. And then that settled down. And then the pandemic, we knew the second wave was starting sometime in March, April, when we saw this upsurge. And this became really a lot in May. We saw about 74 cases of mucomycosis. So I actually just thought, let's look at there are not too many publications actually during this COVID pandemic, but there are a few. And I thought we'd compare about 90 of the cases we've seen in this pandemic with other studies. The first study by Murthy et al. Is from a group of private practitioners, ENT surgeons, oromaxillofacial surgeons, and ophthalmologists in Bangalore, 18 cases. The second study is a meta-analysis by a Western group. Interestingly, 70% of their studies are from India. And then this is our data. So the real significant differences, just want you to note, is that we are seeing a lot more of diabetics, more than 90% of diabetics, as opposed to about 80% or so in the pre-COVID era, a lot more diabetics now. The incidence of orbital and intracranial complications is enormously more. If you remember my previous slide, orbital was about 33%, it's almost double. And so also intracranial complications, 33 here, was about 10% before. Now, in terms of prior COVID and patients having current COVID, I found a big difference between the previous two studies and ours. While they had mostly all patients who were COVID positive 2 weeks prior to the onset of mucomycosis, the majority of our patients with mucomycosis were COVID positive at admission. And so we were treating these COVID positive patients mostly. Okay, we'll go on to the outcomes. Now, if you look at the types of treatment that were, I will just go back. The treatment, because of the involvement of the orbit, you can see that there is a lot more orbital debridement, but the endoscopic sinonasal debridement was almost equal, because there were a lot more, I think, oromaxillofacial surgeons in this group, as well as ophthalmologists. You find a very high incidence of orbital exentration maxillectomy. We did not find the need to do so many. Antifungal therapy, most of our patients receive conventional Amphotericin B, 82.2%, because our patients really can't afford liposomal. It is also not freely available, and that was a very tragic consequence of this epidemic of mucomycosis during this pandemic, for which the government unfortunately was not prepared. What about the outcome? Actually, despite our patients not having too much of orbital exentration or maxillectomies and receiving conventional Amphotericin B, I can see that our results were quite good at 76.1%. 10.9% of them died, which is definitely much better than this meta-analysis of 50% death. But we'll have to look more carefully. Details were not provided about the type of care given for these patients. So this refers to in-house hospital mortality, and follow-up in our series is continuing. So what are the challenges we face with mucormycosis as we go along? There are high costs in evaluation and therapy. There are very few reliable laboratory services in the country for mycology and histopathology. Even in the pre-pandemic era, where every time I went for a talk, I would be asked, which are the reliable mycology and histopathology services in each city? It's difficult because unless they have, follow certain standards, you may not get a proper diagnosis, and that, will obviously influence the delay in treatment. There was a sharp increase in the incident during the first and second waves of the COVID, when most of the resources of governments were all focused on the management of COVID and not on on mucormycosis, unfortunately. Scarcity in the cost as well as the toxicity of antifungals, and the indiscriminate use of steroid without, some patients were actually buying steroid off the counter for mild COVID and taking it. And of course, blood sugars are never monitored in those patients who were diabetic or were not diabetic either. And a lack of awareness of the relationship between COVID and diabetes, both by general practitioners in general and lay people. So what can we do before the third wave comes upon us? And I think that is more important at the moment. First thing is appropriate use of steroids and sugar monitoring. So every time a COVID test is done, if it is positive and one needs to, whether one starts steroids or no, I think there is no harm in doing a GRBS at that point, see whether the person is diabetic, and then have them control their sugars. Highlight the complications of uncontrolled diabetes and steroid therapy to lay public. Provide better labs for mycology and histopathology, and enhance the facilities in many government hospitals. Have clear-cut guidelines on antifungal therapy. Right now, as individual associations have some guidelines, but it's all come up quickly during this epidemic. Ensure the availability of adequate antifungal therapy. We do need a task force on this. Perform well-designed control studies on antifungal combination. Right now in CMC, we are actually doing such a study. And evaluate, I feel, in moderately severe COVID patients, there may be a role for screening CTPNS and prophylactic antifungals, because there is a very high incidence of mucomycosis in this group of patients. So in conclusion, I would just like to reiterate that one should have a high index of suspicion in patients who present with symptoms of facial pain, facial swelling, headache, early loss of vision, ptosis in the setting of COVID. Getting an early diagnosis by sending the specimen for KOH smear, doing a biopsy. Do a thorough clinical examination, stage the disease, and then have a surgical plan. Get the multidisciplinary team involved to address all aspects of the problem. Prompt surgical intervention, and it should be radical and bilateral if you want to avoid repeated surgery. Histological confirmation is the gold standard for diagnosis of mucormycosis. Antifungal therapy should be started early. Ensure that you have adequate stock of these drugs for the next third wave. Rehabilitation is also part of the treatment, so one should have good follow-up on these patients and ensure that they have a good outcome. So with this, I will end my talk, and I will now stop here, and perhaps I don't know whether you would like to have the questions later or after Dr. Rajshekhar finishes his talk.
Yeah. Thank you very much, Madam, for such a wonderful presentation and covering every aspect of the mucormycosis. And we will have I'll monitor the chat box, and we will have the questions at the end of Dr. Rajshekhar's session.
Okay, thank you.
Can you please share your screen, Dr. Rajshekhar?
Firstly, thank you, Dr. Sudhakar, and Rupa, you'll have to stop your and Dr. Satyavara Prasad for this invitation. Most people in the audience may not be aware, I have a special emotional connect with Andhra Medical College. My father was an alumnus of Andhra Medical College way back, of course, in 1949. He's no more. His name was Vedantam Krishna Mohan. He's batch of 49, if I remember correctly. He was a classmate of Dr. Balaparameshwar Rao, who's also no more, the famous neurosurgeon in Andhra. So therefore, it's always a pleasure for me to, get involved in the activities of Andhra Medical College whenever I'm asked to do so. So I readily accepted this invitation to make this presentation. The only hesitation was that as a neurosurgeon, I have very little to do in the management of these patients. And most of the work is done by the department in which my wife works, Dr. Rupa works, that's the ENT department, and she's already shared her experience in the management of mucomycosis. So my talk will be very brief compared to the talk that was given by Dr. Rupa. So how does the CNS get involved in mucomycosis? It's through three routes, either direct spread, along blood vessels, which is by far the most common, that is the angio-invasion, and through the bloodstream, that's hematogenous. The sites which are involved in the brain and just outside the brain are these. The cavernous sinus is the commonest by far, and the adjacent dura, both in the anterior cranial fossa and the middle cranial fossa. And these patients will present with different degrees of ophthalmoplegia. Now, the brain itself rarely gets involved, infrequently rather, I shouldn't say rarely, but infrequently gets involved. And when it does get involved, it's the frontal lobe and the temporal lobe that bear the brunt of the disease. And patients in whom the disease spreads to the parenchyma of the frontal or the temporal lobe will present either with seizures or with altered sensorium or occasionally with focal neurological deficits. But when there are focal neurological deficits, it is most often due to ischemic infarcts involving the territories of the internal carotid artery, the middle cerebral artery, and even rarely the posterior circulation. But most often these patients with brain involvement are asymptomatic, and therefore it's important to screen for brain involvement with an MRI whenever the disease has spread to, say, the orbit or the cavernous sinus. And so this is an example of a patient who's got the left cavernous sinus involved, which is circled here. Compare it with the right cavernous sinus. This is a gadolinium enhanced MRI, and you can see there is thickening of the cavernous sinus, and also the internal carotid artery, you see this on the right side, is well visualized and enhancing. That means there is blood flowing through it. This is empty here. So this is cavernous sinus involvement classically seen in several patients with mucomycosis. And these are a series of patients with brain infarcts. And these images are what are called as diffusion weighted imaging of the MRI, where infarcts are seen as restricted diffusion or white. So you have most of the patients having infarcts involving the basal ganglia or the internal capsule due to the infarction in the territory of the penetration of the perforators, not the major vessels like the anterior cerebral artery or the middle cerebral artery. If at all you do get infarcts in those territories, they are in the watershed zones as seen in these patients. So massive infarcts involving the internal carotid artery or the middle cerebral artery do occur, but not as commonly as those involving the perforators. And here is a patient which is a little unusual involving the posterior circulation. The cerebellum and the pons are affected, and this patient unfortunately succumbed to the disease. It's also important to recognize that in patients with subacute infarcts, like in this patient, if you give gadolinium, you will get enhancement. And this should not be mistaken for cerebritis. This is just enhancement of the subacute infarct. But this is what focal cerebritis looks like. This is a patient in whom there is an infarct of the putamen, head of the caudate. But in addition, you have a T2-weighted hyperintensity in the frontal lobe here. And with gadolinium, there is patchy enhancement with the edema there. You see another patient with the frontal lobe cerebritis, typically seen in the inferior frontal lobe, because that is what is adjacent to the paranasal sinuses, the ethmoids. For example, in this patient, actually, this patient has undergone surgery already. The ENT surgeons have already removed most of the nasal structures, and this patient still has the frontal cerebritis. A patient with temporal cerebritis, very subtle. You see the mucosal, the paranasal sinus disease here in the ethmoids and a little bit in the sphenoid. And you have subtle disease in the temporal lobe. So temporal and frontal cerebritis may not excite the neurosurgeons because it's nothing for them to do, but the real dilemma comes when you're faced with a brain abscess. This is in the frontal lobe, a ring enhancing lesion here with a lot of edema, again a coronal cut of the same. And this patient actually presented to us, this is the pre-COVID era, presented to us with neurological symptoms, came with altered sensorium, low GCS of 13 or 14, with seizures. So we did a combined surgery at the same sitting with the ENT surgeons. We removed this brain abscess, did a craniotomy and removed brain abscess. The ENT surgeons did a radical FES or whatever and removed all the disease from the nose. But see what happened 2 days later. The patient had massive infarcts on the right side, and this patient succumbed 2 days after we had excised this brain abscess. This is the scan done 2 days later, no brain abscess, but instead what you have is all this black area is infarction. Another patient more recently during the COVID era, this is T2 weighted, where you see the brain abscess in the right temporal lobe, lot of edema. Actually, this patient was treated for 1 month after diagnosis with antifungal therapy, but this abscess kept growing. On the T1 weighted, what you see as white is blood. So that is another characteristic feature of brain abscesses in these patients. Not only is it not smooth, sometimes it is like the previous patient, but most often it is the wall is not smooth. There are extensions from the wall into the abscess cavity, unlike what is seen in pyogenic abscesses, but you also have areas of hemorrhage. And that is very well brought out in what is called as the susceptibility weighted imaging as black. So a lot of hemorrhage in this patient. And when you give gadolinium, that's the contrast agent, you see this irregular wall with, like I said, projections into the abscess cavity. After 1 month of waiting, seeing the abscess grow, finally we were left with no option but to operate. We excised this abscess, but the ultimate result was the same. 2 days later, this patient also died. So this is a patient from the pre-COVID era whom we managed conservatively with frontal lobe abscess, again in the upper panel. With gadolinium, you see a lot of disease in the nose and the subdural space here. This is a lot of disease there. But this patient was interesting for the fact that this patient was not immunocompromised, a young patient from Chittoor, 24-year-old male, no immunosuppression, and had 2 types of disease, fungal disease, acute invasive and chronic invasive in the same patient. So this patient survived with just conservative therapy. No craniotomy was done. And this is 3 years later. He came back for his chronic disease. There is still disease in the nose and there is still some dural enhancement, but this patient has survived because this is not the typical acute invasive fungal sinusitis. There is a mixture and the patient was not immunocompromised. So I did a literature search for the neurosurgical management of mucomycosis. There is not much in the literature, unfortunately. This is a review article published a couple of years ago and showing the authors showed one of their cases which was managed conservatively, no craniotomy. Again, frontal lobe cerebritis, like I showed in some of our patients. And this is post-treatment with antifungal therapy, no craniotomy, no neurosurgical intervention, the disease has resolved. So they said the indications for neurosurgery are very limited, only for hemispheric stroke when you do a decompressive craniectomy, obstructive hydrocephalus, which is very rare. I don't know why they put this in at all, because we have never seen such a patient, and lesions compressing the spinal cord, which again is not something that happens with a rhinocerebral mucomycosis. So this, I've highlighted some of their conclusions. Debridement of infected brain tissues associated with severe morbidity and uncertain benefits. There is no significant benefit from surgery in terms of overall survival in patients with CNS invasive fungal disease. Radical excision of fungal brain abscess of granuloma should be avoided in cases of hemispheric stroke, where the raised ICP and herniation are concerns. Decompressive hemicraniectomy can be performed. Another earlier article in NEJM, again, a review article on mold infections of the CNS. The authors again said early selective decompressive hemicraniectomy may prevent devastating secondary brain herniation. Selective stereotactic decompression of edematous intracerebral lesions can be done, but bulk excision of either intracranial abscesses or granulomas should be avoided. So there is one case report, that's all. There is one case report of long-term survival in rhinocerebral mucomycosis published way back in 1998. This patient had been treated by ENT surgeons, and therefore you see all the nasal structures are missing in this scan. And then a month later developed a brain abscess. And this was treated with a craniotomy and excision, and again continuation of antifungal therapy, and this patient survived. So if I were to summarize the neurosurgical management of mucomycosis, when there is cavernous sinus involvement and dural enhancement, which is reported quite frequently by radiologists in patients with mucomycosis, no neurosurgical intervention is needed. If there is brain infarcts, if they are small usually, no neurosurgical intervention, except for large infarcts with midline shift where decompressive hemicraniectomy can be considered. What about parenchymal disease? Cerebritis, no neurosurgical intervention, but if there is a large abscess, I would suggest aspirate. That's about it. Don't try to do a major brain surgery in these patients, because like I have shown and what literature shows, radical surgery is not a good idea in these patients because the outcome is uniformly poor. So it is important to recognize parenchymal disease in patients with mucomycosis. Why? Probably it's associated with a worse prognosis, and there is an issue of penetration of antifungal agents into the brain lesion, and therefore should all patients be screened for brain disease? I think so. I think an MRI is a better option than CT scan in these patients. So I would conclude by saying that most often we neurosurgeons are called to consult on these patients. As Rupa has mentioned, yes, we are called by them because they're concerned when a patient has cerebritis. You will give them anti-epileptic drugs, tell them to carry on and monitor these patients, but try and resist the temptation of doing a craniotomy and removing these lesions, because most often you're not going to do them any good. If at all, probably you'll do them harm. So follow up these cases with antifungal agents. And like I said, if you need to intervene at all, keep them to the minimum. Thank you for your attention, and I'm happy to answer any questions.
Thank you very much, Dr. Rajshekhar. I still remember your excellent talk when you delivered the Srimati I. Sachivati Memorial Oration instituted by Dr. I. Dinaka. Your presence at Andhra Medical College made us very proud, and it was a wonderful session that we had that day. And as usual, you have been so crisp and at the same time so focused and gave a lot of guidelines with regards to the treatments. Thank you very much. And before I take the questions, I would request Dr. Sridhar Chirumuri, my friend from Bronx, Lebanon, to make some comments if he has any. Dr. Sridhar, please.
No, I have no comments. Well, I will go.
Yeah. Thank you. And Naveen has raised his hand. Naveen, if you have any question, you can ask the question.
Sir, thank you, Dean, sir. Hello, everyone. This is to the Madam Speaker, sir. Sir, I just want clarification. Sir, if I mistook, Madam was saying most of their cases were associated with COVID. Most of the mucormycosis cases were associated with COVID, sir. Madam, did they follow COVID, madam, or did they coexist, madam? Most probably they followed COVID, no, madam?
No, the interesting thing is most of these patients came in and the COVID testing gave a positive result. Now, when exactly they became COVID positive is difficult to say, but they were COVID positive. They clearly, some of them were diabetic, most of them were diabetic, but some of them were not. This is different from those who had prior COVID, were given steroid and then developed mucormycosis. Yeah, we are seeing a lot of patients who at the time of COVID itself, being COVID positive, have developed mucormycosis. Now, why this is so, this is something we'll have to look at. It is possible that they have developed acute diabetes, some of them, but worsening of blood sugars, definitely. That is something that COVID can cause.
Madam, thank you, madam. But our principal, sir, is a better person.
I hope that answers your question.
Thank you, madam. But our principal, sir, is a better person to clarify. But most of our mucormycosis cases followed COVID, madam, rather than coexisted, rather than almost one or two cases.
That's right.
Maybe. But
so this is an interesting finding. So this is from 19 patients that we have found that most of them were in fact COVID positive when we operated on them. So we'll have to see why that is so. And as opposed to the classical description of patients getting mucormycosis about 2 to 3 weeks after having a COVID infection. Is it just that they are continuing to remain COVID positive? When did the COVID start? It's not very clear. We'll have to look into that.
Sir, Dean, sir, please clarify, sir. We have 300, you have some 300 odd cases data, sir, 300 odd cases data.
Yeah, thank you, Naveen. Madam, thank you very much for that answer. Yeah, can you hear me now, madam?
Yes, sir. Yes, sir.
Yeah. Madam, can you hear me?
Not very well, actually.
Yeah. Now,
yes.
Madam? Yeah.
Yes, I can hear you.
Yeah. Actually, the natural history that we have been looking at is they are presenting around 3 to 4 weeks after the COVID, like about 2 to 3 weeks after they get discharged from the hospital. That is the usual way of presentation. And only of the 186 patients that we had in King George Hospital till day before yesterday, we had about 4 or 5 patients only had an acute COVID and presented with mucormycosis. And we had an analysis of about 1,500 cases in the state of Andhra Pradesh in the beginning. Now that we have almost double the number of cases. Amongst these 1,500, 90% of them had the COVID before, and later they presented with this mucormycosis, and 10% never had the history of COVID. So amongst the cases that we had, 186, only 2 patients had no history of COVID. So we are thinking of doing the antibody test for them. Maybe they had the mild disease and they got away with that and never realized that they had the COVID. So these are the observations that we had in the state of Andhra Pradesh and in Andhra Medical College at Pathogenesis. And that is as far as the COVID and mucormycosis relationship is concerned. And I agree
with you there. that it is possible that our patients are also the same. Most of them have been sort of treated elsewhere, have had COVID perhaps in the past, and then come, but they are persistently COVID positive when they come in. So exactly when the COVID started is really difficult to say. All we can say is they were COVID positive when they were tested at our place. So it is quite possible that this positivity sometimes can persist for some time. It doesn't mean that the COVID has started at the point that they had the mucormycosis. It is possible that they were positive even 3 weeks before and then developed mucormycosis.
Yeah. Madam, there is a question here that in the chat box saying that what is the time lapse between the infection and the radiological changes? When exactly would the earliest radiological changes show up in mucormycosis?
Now, this is a little variable, but it's usually in terms of hours to days, actually. So you might find that you went into the casualty, examined the patient, and just about found he had some nasal findings, sent the specimen for biopsy. By the time you sort of review the patient with all the results in the evening, you might find he has developed reduced vision in one eye. So the disease has already spread, sometimes even to the cavernous sinus. So it can happen within a period of hours to days. So if you were to do a scan at that time, a GADO-enhanced MRI scan, definitely one would find changes. But it is variable.
Yeah. Well, there was one more question that do the humidifiers that we, can you hear me now?
Yes, I can.
Yeah. Do the humidifiers that we use while administering the oxygen has any role in having this mucormycosis? Is a question from one of the in the chat box.
Yes,
I mean, a lot has been said of the
multiple
factors.
I have been asked this before. And what I understand from reading about this, I didn't mention it because I really don't have data on it. This is a sort of a premise, a presumption. What I've read about it is what happened was a number of industrial places had industrial oxygen given. Now, while industrial oxygen purity is high, the containers in which they are sort of collected, those may not be sterile or clean enough. And I'm told that they are not cleaned regularly. And that may be one route of infection. This is like air conditioners, humidifiers, ventilators, areas that are not regularly cleaned, because this fungus is ubiquitous. It is not something that is found only in one area. And if the patient's host defenses are poor, then they will definitely get the infection. They don't have to specifically get it from humidifiers because you can get it from anywhere. But definitely if you have a higher count of the fungus in, say, a humidifier or an oxygen concentrator or another source from which it can occur, then definitely that could predispose to a person developing mucormycosis. But essentially, it is the host defenses that determine whether a person will get mucormycosis or no.
Yeah. Ma'am, there's one more question which says that are there any studies where non-diabetics contracting mucor post-COVID?
Non-diabetics, did they develop mucor, is it?
Yeah.
Okay, so non-diabetics who were known to be non-diabetic, it's very unusual in India for somebody to say, I check my sugars regularly and I know I'm not diabetic. That practically never happens. But if a person has, maybe checked a year back and then developed diabetes, acute diabetes, that has been shown. I alluded to that study in the SARS-CoV-2 time that coronavirus can damage the islet cells of pancreas and produce an acute diabetes. But we too have seen patients who are absolutely immunocompetent, have no diabetes, and yet have developed mucormycosis. So this constituted about 5 of these 90 patients that I described. Now, why it is they've developed mucormycosis? Was there some, so hitherto untested immune dysfunction? It's difficult to say, but it's quite possible that they had something like that. And that needs to be evaluated. But yes, even in the pre-COVID era, we would get about 2 or 3 patients per, I would say about 4 patients per 100. 4% of patients would be absolutely immunocompetent and have no diabetes mellitus and yet develop mucomycosis. And these patients generally actually did well with therapy.
Yeah, thank you, ma'am. And there are a couple of questions for Dr. Rajshekar. Dr. Rajshekar, are you online?
Yeah, I'm here.
Yeah. And Dr. Rajshekar, it said that in the pre-COVID era, the rhinocerebral mucomycosis in patients with diabetes ketoacidosis was conventionally managed with the radical craniofacial resection as the recurrence was inevitable. And these patients had 100% mortality. Then why is this conservative approach now? Is it because the outcome is poor, is the question? Or hence the futility of the surgery, or is it because there is a good response for the antifungal therapy?
No, that's a very good question. But I must clarify that even in the pre-COVID era, we hesitated to do radical surgery. And it's not only us. As I showed in the reviews, both the reviews that I showed you, they also suggested. One second. You have to reduce.
Yeah, I'm just trying to look for it.
Sorry for the echo. There is an echo. You have to reduce your. Okay, fine. So in the pre-COVID era also, we hesitated in doing radical surgery because, as I showed you, it's not that we never attempted it. We did those 2 cases were both done. One was pre-COVID and one was COVID era. But you saw the results. Both patients died. I'm not suggesting don't do any surgery. Actually, Dr. Bhaskar has asked a question after that, saying that isn't the surgical dictum to let out pus? I agree, but do it as minimally invasively as possible. Don't try to do major surgery in these patients is all that, not that only we are recommending, but that's what literature says. It's not my sort of recommendation or something that I have come up with. That's what world literature on it. This is all that is available to us. If there is some other literature showing this is what works, we'll be happy.
Naveen, can you put your phone?
But right
can
now,
you mute your phone, Naveen?
Neurosurgical intervention should be neurosurgeon should be circumspect about how much they do for these patients. Let out the pus, I agree, or do decompressive craniectomies if the intracranial pressure is elevated and the patient is in the danger of succumbing to herniation. I agree with that, but as far as possible, don't go into the brain too much. Don't try to be aggressive with your brain part of the parenchymal part of the surgery. Because the ultimate outcome is determined by the angioinvasion and the effect of the antifungals on the fungus. As I showed you, the reason the patient with the brain frontal lobe abscess died was because the patient developed massive infarcts, which cannot be prevented by a surgery. It's the disease itself, is the agent itself that has to be controlled. And that is the function of the antifungal agents. It's not the surgeon. But I agree with Dr. Bhaskar that we should let out the pus, but try to be minimally invasive. Just stereotactic aspiration or just a burr hole and aspiration is what I would advise.
Yeah. Thank you very much, Dr. Rajshekar. Thanks for answering that question by Mala Bhaskar. I should thank Dr. Bhaskar also because when we discussed, he's the one who said that for this important session, you should be there, you and madam should be there as speakers. Thank you, Bhaskar, for asking that question and also helping us. And we have one more question, as well as a comment from Dr. Jogi Pattisapu. He said that will there be any relationship between this and the Delta variant that we are going to see more in future, because a lot of hype exists. Would this mucomycosis will also be more in the days to come?
Yeah, so yes, definitely we're expecting a lot of problems with the Delta variant. I do feel that diabetes, the incidence of diabetes is going to really go up. Acute diabetes is something that we now know is produced by the coronavirus. This was demonstrated as far back as 2008 when we had the SARS-CoV-2 infections. And that is certainly something that we need to be aware of. Now, the complications of uncontrolled diabetes, we know all of them. This time it is mucomycosis. It may continue to be mucomycosis or some other new complication may occur. So we really need to be on the watch out. India has the second largest number of diabetics in the world. Interestingly, the US has the largest number of diabetics in the world, but India has the largest number of mucomycosis cases in the world. Now, why is that? That is simply because we do not have proper healthcare facilities to keep the diabetes under control. And if we have to address something most urgently, it is healthcare facilities at the primary healthcare level and primary and secondary healthcare level through the government mechanisms, because that is what patients can afford. They really can't come to private hospitals. And if we improve our healthcare, primary healthcare, I see that this may not be such a big problem then. That is why mucomycosis has hit us so badly during this pandemic.
Yeah, and same way, Dr. Jogi also asked that, we had 11,000 cases of mucor in India during the second wave, not so in the first wave. Will the variant has to do anything with this? If so, can the new variants can cause more trouble in future?
I totally agree with that premise. It's quite possible that it is the variant that has caused the sudden upsurge in the second wave, not so obvious during the first wave. Definitely, yes. And I also feel before the second wave, a lot of new drugs, these monoclonal antibodies and things were introduced actually in that period between the first and second wave from various studies, and thereafter all of these things were discounted. Whether they also, because patients literally just bought them off the counter, whether that also contributed to some extent in the high prevalence of mucomycosis.
Yeah. Actually, there was a question by Dr. Malleshwara, who is a regular visitor to this particular forum. He asked, is there any relationship between the mucormycosis and the the immunization, the vaccination that they take? Is there any data to show whether people who have got vaccinated got this mucormycosis later? I think that needs to be studied, I suppose. We have to study as to how many people got vaccinated from the ones who are suffering from the mucormycosis with this. It's a good point to be that has been made. I think we'll look into that. If there are any questions, people can. Vijay Shekhar he raised his hand. Dr. Vijay Shekhar, the neurosurgeon from our King George Hospital. Vijay Shekhar, please go ahead.
Sir, good morning, sir.
Good morning. Good morning.
Sir, very nice to hear you again.
Thank you.
Actually, I was a student of Dr. Rajsekhar for some time, and I have been to CMC Vellore in 2001 itself. When I have been there as an observer. Nice talk, sir. And sir, here we have some practical experience in our King George Hospital, because the number of cases we are seeing is increasing daily. We have so far treated almost 190 cases of mucormycosis, and out of which almost 50%, about 80 cases have been operated, because predominantly, as Madam was mentioning, by ENT surgeons, by the FES and extended FES. And out of these cases, sir, we have almost 9 cases were operated so far for their intracranial extensions. And sir, we came across 2 cases who have developed early. Actually, by the time of their presentation, they have early cerebritis along with the orbital and sinal disease. But when the initial surgeries were performed by ENT and orbital ophthalmic surgeons and started an Amphotericin B, they resolved initially. But after 10 days or 2 weeks, they have worsened by way of radiological increasing and abscess formation. So we thought what best will be the approach. And as Madam was showing in one of the slides, post-exentration, there was a collection in the frontal and temporal folds. So same situation we encountered, sir, here also. So what we have did is we have opened the orbital wound, and by drilling the sphenoid wing, we have entered directly and tapped. As you were mentioning, the same minimal invasive procedures we have done in these two cases by a transorbital approach through the excentrated globe. And almost 4 cases we have done endoscopically. I can show some, I'm just checking. Some of the cases developed basifront abscess, bilaterally. So these are drained endoscopically, and 2 cases we have excised, because as you were showing the temporal lobe abscess with thick capsule with minimal craniectomy, we have excised. So this is our experience with regarding to COVID, sir, with neurosurgical intervention. 9 cases we have operated so far. Just to share with you, sir, and with all the other audience.
Yes, thank you, Dr. Vijay Shekhar. And I would agreed entirely with your approach to the management of these patients. And this is exactly what I was emphasizing, that the neurosurgical intervention should be as minimal as possible. And I think you did the right thing in all these 9 cases. And I would go with you and continue to do the same for patients in the future too. The role for aggressive, excision of abscesses and the infarcted tissue is very, very doubtful in my mind, to my mind. And again, we must also recognize that we as neurosurgeons really play a very marginal role in the ultimate outcome of these patients. Because the ultimate outcome is determined by the comorbidities, the response of the fungal agent to the antifungal treatment, and also the ability of the patient to continue with the therapy and complete the therapy. That's another major problem. That, as Rupa has pointed out, several patients drop off from the therapy because of either cost constraints or they develop the side effects of the plain amphotericin and they stop the therapy. So all these play a role in determining the outcome, ultimate outcome. So as long as we recognize that and do what is absolutely necessary and not be too aggressive, I think we will do them good.
Yes, sir. Thank you, sir. Sir, if you if I am permitted, can I share some of the pictures?
No. Vijay Shekhar, I think we are running out of the time, and probably we can have one more session on this when you can present your video. Okay. So with that, I thank Dr. Rajshekhar and Dr. Rupa Vedantam for the excellent lecture, and this being a very important milestone, the 75th in the series. I always feel that this could not have been a better session than what we had today. And I thank each one of you for sharing your experiences and interacting with the speakers. And thank you again, Dr. Rajshekhar and Dr. Rupa. And please be in touch so that we will have more sessions of this kind, which will be very educative. Thank you all. With that note,
thank you. Thank you.
I end this session here. Thank you.
Thank you.
Thank you, Sridhar.